Hi everyone, my name is Katie Wagner. I'm a current physician assistant student in the class of 2022 at the University of Mount Union, and this is my master's capstone project. This is on appropriate methods of pain reduction during intrauterine device insertion. I wanted to start off this presentation with a clinical scenario. This is a good example of something you might see in the real world. So my patient today is MP. Her chief complaint today is that she would like a new form of birth control. MP is a 22-year-old female who presents to the GYN office seeking a new form of birth control. She has been on oral contraceptives for 4 years, but reports that she often forgets to take her daily pill. She's recently started a new relationship and would like a contraceptive option that she doesn't have to worry about. She's never been pregnant before, but would like the option to conceive in the future. She states that her menstrual cycles are regular and occur every 28 days. She does admit to some dysmenorrhea during her menstrual cycle, which she typically takes ibuprofen for pain relief and has no issues with that. It relieves her pain. She has no other complaints today, and she would like to discuss contraceptive options that would be a good fit for her going forward. To give some more history on MP, her past medical history is significant for migraine without aura and generalized anxiety. Her surgical history is not significant, nor are her allergies. And for medications, she is taking sumatriptan 25 milligrams just as needed, as well as venlafaxine 75 milligrams, 1 tablet daily. So overall, she's a pretty healthy young woman. Her family history, she has no family history of endometriosis, PCOS, or other GYN disorders, including any uterine or ovarian malignancies. I didn't include any other family history just because I felt that it wasn't really pertinent to this clinical scenario. Her social history, the patient is a graduate student. She currently lives alone in a 1-bedroom apartment. She's in a monogamous relationship. She does admit to drinking 5 to 6 seltzers per week in a social setting and denies smoking or any recreational drug use. For her review of systems, I went over several systems. All of them were largely benign. No pertinent findings for this. Her physical exam was similar. No pertinent findings. I did want to include the pelvic exam. It was normal genitalia without external lesions, exudate, or discharge. The vagina and cervix showed no lesions, inflammation, discharge, or tenderness. So she was healthy and really no problems identified so far. Because she did have a normal review of systems and physical exam, labs and diagnostics were not needed at this time. Moving on to the assessment and plan. Again, since everything was rather benign and no labs or diagnostics were needed, and she really wasn't coming in for an acute problem or a complaint, the assessment and plan is pretty straightforward. This is a well-developed young adult female who desires long-acting contraception. So discussing contraceptive methods is the next step in this scenario. So now that I presented the clinical vignette, I wanted to give a good background on unintended pregnancy and contraceptive use and why this is important to the case. So in the United States, up to half of all pregnancies are unintended. About 50% of these can be attributed to failure, misuse, or incorrect use of contraception. So this is a pretty significant number, 50%. And with this, health disparities are more prevalent among unintended pregnancies. So Black and Latino mothers have a 50% chance of experiencing teen pregnancy. Half of all teen mothers do not end up obtaining a high school diploma. This can significantly hinder economical and educational opportunities, specifically in women of color and women with low socioeconomic status. And then unintended pregnancy rates are up to 5 times higher in mothers of low socioeconomic status and affluent mothers. So you can see how this creates a large barrier and discrepancy in health disparities as a whole. There are also a lot of associated maternal and fetal health consequences of unintended pregnancies. So maternal and fetal health consequences are higher in unintended pregnancies, specifically in adolescents. Some of the complications of this include higher risk births and birthing complications, increased rates of maternal and postpartum depression, and decreased long-term growth and development, especially in children of unintended pregnancies. And kind of going back to the health disparities, you can see how these problems end up compounding, specifically in minorities and those of lower socioeconomic status. And kind of piggybacking off of that, this ends up creating kind of a trickle-down effect of increased public and health costs. So higher rates of unintended pregnancy, specifically with mothers of low SES and those who don't have access to as many resources, result in higher public health costs. This contributes more taxpayer dollars toward maternal and infant care. So because of this, I think it's really important to increase advocacy and adherence of contraceptive methods. This could in turn decrease unintended pregnancy and overall decrease public health costs associated with healthcare disparities as a whole, and kind of just contribute to making society a little bit better, specifically for minorities and people with low socioeconomic status. So now that I have given some sufficient background on why preventing unintended pregnancies is important, I wanted to talk about some effective ways to do that. So long-acting reversible contraception is a really great method that we have developed. So LARCs are the most effective form of contraception available today, and they have failure rates of less than 1%. And we'll talk about this more, but that's really significant compared to other forms of contraception available. LARC is a contraceptive device, and it stays in the body over a period of several years. And it provides contraception without any intervention by the user. So there's no need, if you have a LARC, there's no need for any intervention. You kind of just set it and forget it. Some available options today are IUDs. These can consist of hormonal IUDs, such as Mirena, Kyleena, or Liletta. These are just brand names. There's more options out there, but these are some of the more common ones. There's also non-hormonal IUDs. These are typically copper. One of the most common ones today is Paragard. And I did want to mention that subdermal implants, such as Nexplanon, are good examples of another form of long-acting reversible contraception. I won't discuss those today, but I did want to mention them as a viable form. So how do LARCs compare to other contraceptive methods? Studies have found that user-dependent forms of contraception, such as oral contraception, vaginal rings, and transdermal patches, they have failure rates up to 20 times that of LARCs. So that's really significant and a huge jump. Despite their effectiveness, oral contraceptive pills remain the most widely used contraceptive method in the US. So some might say, why is that an issue? It's still a form of contraception, and it is still effective if used correctly. But it can be a huge problem because it's a completely user-dependent form of contraception. OCP failure rates can range from 9 to 18%. And when you're comparing that to LARCs, which have failure rates of less than 1%, that's a really significant jump. This can be from a multitude of things. OCP users often experience side effects that can cause a woman to discontinue or be less compliant with their contraception. This includes weight gain, headache, breast tenderness, or breakthrough bleeding. There are a lot of other side effects. And this isn't to say that you can't have side effects with other forms of birth control, but I think this is important to mention because OCPs are user-dependent. If you were to experience some of these side effects, many people would just stop taking their contraception, which isn't an option with LARCs unless you were to take the steps to get them removed. So there are a lot of barriers to LARC use, and there are a lot of benefits to increasing access to LARCs. So studies have demonstrated that women are often hesitant to start a contraception they cannot control the administration of. There are also decreased rates of education surrounding LARCs, as well as decreased access to LARCs in many marginalized communities. This contributes to higher contraceptive failure rates and more unintended pregnancies. There are a lot of benefits to increasing LARC use. It gives women the freedom to choose when they are ready for children, and in turn, this gives them more opportunities for higher education and increased earning potential down the road. It also can increase maternal and fetal health. So, studies found that rapid repeat births were decreased 12% when using a LARC versus a user-dependent contraception. And by rapid repeat births, we essentially just mean when a woman gives birth and then directly after or in a short period of time following that birth, she gets pregnant again. LARC users are also about 20 times less likely to become pregnant compared to those using user-dependent methods, such as oral birth control. Now I wanted to jump into talking more in depth about intrauterine devices, or IUDs. So IUDs are contraceptive devices, and these are placed in the uterus. These are inserted by a healthcare provider, and depending on the brand or manufacturer, they can remain in the uterus for 3 to 10 years. So how do these work? So again, I did discuss kind of hormonal and non-hormonal IUDs. I'm going to go a little bit more in depth. So hormonal IUDs contain a hormone called levonorgestrel. This essentially continually secretes very small amounts of progesterone each day. This progesterone is a hormone, and its purpose is to thicken cervical mucus and inhibit sperm motility and endometrium growth, and this prevents you from getting pregnant. Non-hormonal IUDs kind of work in a similar way, but they don't utilize any hormones. So these IUDs are copper, and what copper does is it inhibits sperm motility and survivability through a localized cytotoxic inflammatory response. It's a little bit different from hormonal, but kind of, has the same end result. It prevents you from getting pregnant. And on the left, there is a picture. This is what an IUD looks like, and it is about the same size. So to go over IUD placement, it is a 5 to 10 minute procedure, and this can be done in office by a provider. So the first step of this is obtaining a negative pregnancy test. This is important because you wouldn't want to insert something into a woman's uterus if she was pregnant, and you especially wouldn't want to induce cervical dilation, which sometimes is necessary. After that, a bimanual exam is performed. This is just to determine uterine position, and then a speculum is inserted after that to visualize the cervix. The next step is cleansing the cervix with a solution, typically iodine. If you have an allergy, other solutions can be used. And then a tool is called a tenaculum, is used to anchor the cervix in place. After that, a uterine sound is inserted through to the cervical os. So this is used essentially to measure the depth of the uterine cavity and prevent any perforation when inserting the IUD. Because the inserter has to go through the cervical os, cervical dilation may be necessary. Once the sound is removed and the IUD is inserted by passing again through the cervical os. And then once the IUD is in place, the tenaculum can be removed from the cervix and the IUD strings are trimmed. So here's a visual aid just to help. It's hard, kind of to think of those steps in your head, but you can see that the inserter is going through the cervix and into the uterus. And then as it's removed, the IUD is placed in the uterus, and you can see the strings there, and those are trimmed to the desired length. So because this is a procedure, there is often pain with insertion. So about half of all women reported experiencing moderate to severe pain during insertion. So tenaculum placement and cervical dilation have been frequently reported as pain-inducing, specifically among the nulliparous population. And you can see on the top right corner, I included a picture of a tenaculum. The ends are used to grasp and hold the cervix in place. So currently there is no universal recommendation for pain control during the procedure. However, varying methods of pain control have been trialed, but usually insertion is completed with really no pain control measures provided. So there are several barriers to implementation of IUDs. So as I discussed previously, only about 5.5% of women in the US utilize IUDs as a form of contraception. That's pretty low when you think about how efficacious they are and how effective they are. So the insertion procedure is a large barrier to this, with many women, specifically nulliparous women and women who have only undergone cesarean section or those who have not experienced cervical dilation, reporting high rates of pain. Difficult insertion can be correlated to higher pain levels, and studies have shown that nulliparous women are 1.6 times more likely than multiparous women to have a difficult insertion. Some other barriers to implementation are anticipated fear. So perceived anxiety leading up to an insertion can contribute to a more painful experience for the user. IUD insertion experiences are frequently discussed on social media platforms. This can contribute to more shared negative experiences and misperceptions about IUDs as a whole. Studies have shown that about 50% of women have been told negative stories by friends or family about IUDs, and then 42.8% of women have been found to have existing negative perceptions about IUDs, which is pretty significant. That really contributes. There can also be increased potential for complications with insertion. So although IUD use still isn't up to its full potential, its use is rising, and with that, there are new challenges to insertion and removal of these devices. So varying uterine structure and tone from individual to individual can make removal and insertion difficult. Nulliparous women specifically have narrower endocervical canals, making insertion difficult and often painful. Transgender males can also present with vaginal atrophy due to testosterone use. This can complicate both insertion and removal. And I did want to note that IUDs are great options, especially for transgender males who still have a uterus. They still need contraception, and they still need viable options. So deep insertion, excess weight gain, or strings that are no longer visible, they can also make removal more difficult. So in these cases, manipulation with either forceps, hemostats, or cervical dilation may be necessary, and this can all induce higher levels of pain and discomfort. So now that I have given you guys a good amount of background into unintended pregnancy, long-acting contraception, and IUDs, I wanted to introduce my research question. So I asked, is there an appropriate method of pain reduction providers can use to decrease pain and discomfort associated with intrauterine device insertion in women? To go over some of my methods I used in this research study, I used the PICO model. This stands for Population Intervention, Comparison, and Outcome. This was used to develop an evidence-based practice guideline for analgesia methods during IUD insertion. Scientific databases PubMed and EBSCOhost were also utilized. My inclusion criteria was as follows. So recent publication within the last 10 years, availability in English, relevant to the research question, and peer-reviewed articles. And then my exclusion criteria were any articles that were unavailable due to cost. For my results, 9 studies were identified in total. And I wanted to mention that all of these results utilized a pain score scale called a visual analog scale, or VAS for short. This uses a 10 centimeter horizontal line to rate pain scores. So 0 centimeters would correlate to no pain, and 10 centimeters would correlate to the worst pain ever experienced. So these are really commonly used pain scores. You've probably seen them in all kinds of other facets of medicine. The first article I discussed was by Bastian et al. So this was a prospective observational study. It was done in 2019, and it studied IUD placement through the direct method of insertion. This is a novel method of insertion, and largely it's been utilized in France, and it hasn't really been observed many other places. So with the direct method, the inserter is inserted up to the cervical os, but it does not pass through as it would during the standard method. There's really no need for cervical dilation or use of a hysterotomer or tenaculum in this method. And again, the tenaculum for cervical dilation is typically the most pain-inducing part. This study included 535 women. 281 of those underwent IUD insertion via the direct method, and 254 underwent insertion via the standard method. And I included this table just to summarize my results. So they actually broke up the VAS pain scores by comparing nulliparous and multiparous women, and then just nulliparous women. So discussing first results with multiparous and nulliparous women, with the standard method, the mean pain score for those groups was 3.3 centimeters. And you can see that this decreases to 1.9 centimeters when utilizing the direct method. And then when you jump over to nulliparous women, their group rated a mean pain score of 5.1 centimeters with the standard method, and this decreased significantly to 2.8 centimeters with the direct method. So this really demonstrated a pretty significant decrease in pain scores. The next research study I utilized was by Daikin et al. This was a 2021 randomized controlled trial. It compared oral analgesia consisting of tramadol 50 milligrams to verbal analgesia just prior to IUD insertion. So a little bit of background: verbal analgesia consists of providers repeating reassuring phrases in a low tone and pitch prior to the procedure, as well as maintaining communication and explaining the procedure at each step. In this study, 45 women were included, and it only included nulliparous women. No multiparous women were included in this. Overall, there was no significant difference in VAS pain scores between groups. The mean pain level was 4.5 plus or minus 1.6 centimeters for tramadol, and 4.8 plus or minus 2.4 centimeters for verbal analgesia. Though this might not seem significant, I thought it was efficacious that just verbal analgesia could contribute the same amount of pain control as a pharmaceutical agent. However, there was no control group included in this study, so it made it difficult to establish a baseline pain score. The next study evaluated was a 2018 randomized control trial. This compared several interventions during IUD insertion, consisting of paracervical block, oral misoprostol, oral naproxen, or a placebo. 200 nulliparous and multiparous women participated, and pain was measured during and after insertion. Overall, there was no appreciable reduction in pain with any intervention. Paracervical block created a potential pain increase. With that, it requires an injection prior to IUD insertion, so you have to have additional speculum insertions and increased potential for toxicity around that cervical area where it's being injected. Misoprostol and naproxen showed no difference in pain reduction versus a placebo. I did want to include that researchers did not find participants to elicit severe pain, And overall, they didn't find analgesic intervention necessary. This really varied from my other studies. Almost all of the other studies included found that pain was elicited during this procedure. So Perez-Lopez et al. Was my next included study. This was a 2018 meta-analysis of 11 randomized controlled trials, and this evaluated multiple forms of lidocaine during IUD insertion. 11 studies in 1,458 nulliparous and multiparous women were included. Lidocaine formulations that they included were local lidocaine gel, spray and cream, lidocaine with prilocaine, and then paracervical block lidocaine. Pain was measured during tenaculum placement, during IUD insertion, and after IUD insertion. And overall, results found that topical lidocaine and paracervical block lidocaine were effective. So topical lidocaine gels, creams, and sprays overall showed a modest reduction in pain during and after IUD insertion. Lidocaine with prilocaine showed significant pain reduction during and after. And then paracervical block reduced pain during insertion, but again, it added that additive pain effect prior to the insertion. The next study I included was a meta-analysis. It was completed in 2014, and it compared 13 randomized controlled trials evaluating multiple forms of analgesia. So 13 studies and 1,353 nulliparous and multiparous women were included in this. Their analgesic options included intravaginal and oral misoprostol, topical lidocaine, paracervical block lidocaine, oral tramadol, oral naproxen, and topical nitroprusside gel. So of those interventions, only paracervical block lidocaine was found to elicit significant pain reduction. The mean difference in VAS pain scores was that it decreased pain 2 centimeters compared to only a decrease in 8 centimeters with control groups. 0.8 centimeters. So with misoprostol, the VAS scores were actually higher. They saw an increase of plus 0.7 centimeters compared to control groups. And then the other analgesic forms really made no appreciable difference. This study did want to note that since there were a large amount of studies and participants included, there really was no uniform way of measuring these pain scores that were practiced. The next study I included was a randomized control trial. It was conducted in 2015, and it studied something called short-acting 4% viscous solution lidocaine. For short, this can be referenced as SHACT. So SHACT is a topical lidocaine, and it's theorized to prolong delivery of lidocaine to tissues. So this could be, to the cervical tissue or wherever else it is utilized. Of this sample, 233 women were included. It was largely nulliparous, and then VAS scores were measured during insertion, within 10 minutes of insertion, 2 hours after insertion, and 4 days following insertion. So they were measured at many time intervals. Overall, SHACT showed significant pain reduction. It was most prevalent within 10 minutes of insertion when the highest pain level is experienced. And then mean VAS scores of 2.83 centimeters were noticed with the SHACT, and this is compared to mean pain scores of 4.42 centimeters with the control group. So you can see there's a significant reduction of pain with the SHACT. And this was about a 36% pain reduction as a whole. Tassi et al. Was my next included study. This was a 2020 meta-analysis of 14 randomized clinical trials evaluating misoprostol use before IUD insertion. 1,598 women were included in this study, with about 650 nulliparous participants. So there was a good mix. So vaginal, buccal, and sublingual misoprostol were used. Misoprostol, typically, to give a little background, it's used to induce cervical dilation and uterine contraction during GYN procedures. It's thought to facilitate easier IUD insertion by providing less need for cervical dilation and resistance. Overall, the VAS scores in this study showed no appreciable reduction with any form of misoprostol. Nulliparous women actually noted more pain with the misoprostol. Nausea, vomiting, and cramping were also noted at higher rates, specifically in sublingual and buccal administrations. And then cervical dilator use and insertion failure were notably lower, but overall they didn't contribute to decreased pain scores during insertion. Gemzil, Danielson et al. Was another research article I used. So this was a 2019 narrative review of 43 randomized controlled trials comparing multiple forms of analgesia. So oral analgesia, such as ketorolac, naproxen sodium, and ibuprofen were used. Misoprostol, local anesthesia, such as topical lidocaine, lidocaine with paracervical block, and lidocaine prilocaine were used. And then that Schacht lidocaine solution was also used. Overall, oral analgesia showed minimal to no reduction in VAS scores when compared to placebo groups. Misoprostol had mixed results. One study did show a reduction in VAS scores in nulliparous women or women who had only underwent cesarean delivery and had no exposure to cervical dilation in the past. Overall, though, increased abdominal cramping was noted, and then other studies demonstrated either no effect on pain or increased pain. Local anesthesia, so for that, local lidocaine spray demonstrated a moderate decrease in pain scores. Local lidocaine paracervical block did moderately decrease pain scores as well, but it provided that increased pain additive pain scale during the injection. And then Schacht lidocaine indicated appropriate reduction in pain scores during all insertion steps, which was the most reassuring finding found in this study. The last study I utilized was a 2018 randomized control trial. It studied vaginal misoprostol for pain control before IUD insertion. 120 women were included in this study, and this only included women who had previously undergone cesarean delivery. So again, no cervical dilation. 600 UGs of misoprostol was given 6 hours prior to IUD insertion. So overall, misoprostol was associated with a 0.7 centimeter reduction in pain compared to the placebo group. However, nausea, vomiting, and cramping were noted in 16.7% of women who took the misoprostol. So again, it increased systemic side effects. So now that we have reviewed all of my associated findings and articles and gone over a good amount of background information on unintended pregnancies and LARC use, I would like to discuss my findings and go over some significant outcomes from these studies. So the first thing I wanted to start with was non-pharmacological interventions. So these included the direct method of insertion as well as verbal analgesia. Again, with the direct method of insertion, this proved to be efficacious, and it did indicate reduced pain scores overall, specifically in nulliparous women. It is safe and economically feasible. However, it would require additional training of practitioners. This could, skew technique. It's a highly variable thing. It's not the same as just giving a dose of a pharmacological agent. It kind of induces more training as a whole, and that can vary from person to person. Verbal analgesia showed to be largely efficacious. However, there was no control group. So overall, both of these studies proved successful at pain reduction, and they are really feasible implementations. However, more studies would be helpful. But implementing either or both of these methods together, I think, could be a consideration going forward. The next topic was oral analgesia. So there were several methods studied, including tramadol, ketorolac, ibuprofen, and naproxen and naproxen sodium. So overall, tramadol, ketorolac, and ibuprofen showed no significant pain reduction. Naproxen and naproxen sodium did show some mild pain reduction after the insertion, but overall it didn't have any effect during insertion. So as a whole, oral analgesia is not recommended for use in pain reduction during IUD insertion. Lidocaine formulations were really prevalent in a lot of the studies. So lidocaine gel, spray, and cream, and then lidocaine prilocaine were all studied. So lidocaine gels, sprays, and creams were associated with moderate to no pain relief. It kind of varied. Moderate pain reduction was noted during and after insertion, but largely these interventions made no difference. Lidocaine with prilocaine did have variable results. So pain reduction ranged from either non-appreciable to significant in some studies. These results were variable, but overall they were more promising than the other topical lidocaine solutions mentioned. SHACT was another category I wanted to discuss, so it did show somewhat promising results. Pain reduction was noted in all the studies that SHACT was involved in. Significant reductions in pain were noted specifically during parts of insertion associated with higher scores, and we discussed this, such as tenaculum placement and cervical dilation. Samples for these studies were also largely nulliparous, and again, nulliparous women contribute to higher pain scores than other women, so the fact that this was efficacious in that group was reassuring. Overall, SHACT demonstrated a plausible method of pain reduction that could be used for IUD insertion in the future. Paracervical block was also implicated in many studies. So paracervical block, either with 1% or 2% lidocaine, did largely decrease pain during insertion, but it introduced an additional painful stimuli during its administration. 2 out of the 3 studies that it was noted in showed appreciable pain reduction during the insertion, but again, only with that additive pain scale prior to. All included studies with paracervical block reported an increased pain or toxicity prior to the IUD insertion. Because of this reason, overall, paracervical block proved efficacious for pain relief during insertion, but I think it presents with many barriers that discourage its routine use as an analgesic option. It's really not great to induce another pain scale prior to this procedure. Lastly, misoprostol was also discussed in many studies. It was implemented in 4 studies, and all of these studies found a unanimous association with increased systemic side effects. This includes nausea, vomiting, and abdominal cramping. Abdominal cramping was the most significant side effect. It contributed to increased pain in many participants. So overall, misoprostol was not associated with a significant reduction in pain during insertion. Though it was noted to make insertion easier for providers, it really didn't show efficacy during the procedure and likely shouldn't be used for pain reduction. There were several limitations to this study. So first and foremost, pain is subjective. It does vary by individual. It can be difficult to obtain an accurate baseline among the entire population. This really makes providing a universal recommendation for pain difficult, just because there is so much variation between individuals. Insertion experience can be impacted by practitioner experience as well. So more experienced providers may provide less painful insertions, or vice versa. Again, it really depends on the individual. It's another variable that's also difficult to control. 2 databases were only 2 databases were utilized in this study. So PubMed and EBSCOhost were the only ones I used. Had I used more, I may have been able to yield more results. And then only 1 researcher contributed. So because it was just me, I could have introduced bias and limited my analysis potential. Going forward, I think there are several recommendations for future research on this topic. Introduction of new methods and techniques for pain reduction is really important. So this study largely ruled out options that provided little or no pain control. This could be oral analgesia, misoprostol, and various lidocaine solutions. And I think more research is needed surrounding novel methods that were effective, such as SHACT and the direct method. Quantifying pain scores during insertion is also really important. Specific populations, such as nulliparous women or women who have only underwent a cesarean section, have proven to experience more pain than multiparous women with previous vaginal deliveries. This could really skew pain scale scores. So, quantifying that and maybe making more specific, population-specific recommendations is important. It's also important to increase advocacy for pain control measures. Making it known that significant pain is experienced during this procedure, as we have seen from research included, should aid in getting the necessary future interventions that will help solidify guidelines going forward. So overall, my conclusions. So I think there are many plausible recommendations for pain reduction, but so far there's not a lot of concrete evidence supporting the use of one singular intervention for analgesia. So direct method and SHACT I felt largely provided the most utility in this study. However, further research is needed to solidify these results as they are rather novel methods. Oral analgesics and topical lidocaine were largely identified as unsuccessful, and then paracervical block and oral misoprostol were associated with additive pain or more systemic side effects, which really deemed them unhelpful. Overall, I feel that further research is needed to provide better guidelines for care in the future and just to better guide our overall understanding of pain and what we can do to prevent that. So these are my references. This is my image reference. Thank you for listening. If you have any questions, please feel free to reach out to me and I would be more than happy to answer them. Thanks.